My name is Russ Derry. I'm the Director of Education at Epilepsy Foundation of Michigan, and today's Learn and Share conference call is entitled Epilepsy Management in Women and Girls. And we're very happy to have with us today Dr. Basel Assaad, who is an epileptologist with Henry Ford's Comprehensive Epilepsy Program. Dr. Assaad, welcome, and can you please introduce yourself and give us a brief overview of your experience working at Henry Ford, your clinical and research interests, and also your experience with this particular topic?
Sure. Thank you, Russ. I'm very glad to be here. Well, I'm an epilepsy specialist. I have been working at Henry Ford for about a little over 10 years now. In fact, I did my residency and fellowship in Henry Ford Hospital. In Henry Ford, it's a tertiary epilepsy center, meaning we get referrals from all over the state. So we see a variety of cases, and we see a lot of complicated cases. I work in epilepsy unit. I see surgical patients. I do long-term EEG, critical care EEG monitoring, and a lot of epilepsy patients. Quite a few number of my patients are women in childbearing age, which is the topic we're going to talk about today. My interest in the topic actually started early in my residency. In fact, part of our training is giving a grand round at the end of our training, and the topic for my grand round was women with epilepsy and the issues that they face and how to manage them. So I have been interested in this topic for quite some time.
Great. So let's start by talking about reproductive hormones and the role that they play in epilepsy. Can you just kind of give us a brief overview of reproductive hormones, particularly in relation to puberty, the menstrual cycle, and then menopause?
Sure. Well, we have a lot of clinical and preclinical evidence that reproductive hormones, and by reproductive hormones I mean especially estrogen and progesterone, they have effect that might be pertinent to epilepsy. The most compelling evidence is that progesterone has an anti-convulsant effect, meaning it lessens the seizures or has anti-seizure effects. Progesterone gets metabolized to a substance called allopregnanolone, which inhibits seizures through by working on the brain by modulating a neurotransmitter, which is a substance in the brain called GABA-A. And by doing this, it inhibits seizures. The drop that happen in progesterone level, like around menses, might lead to seizure exacerbation in some women just before menstruation. This effect is the basis of using progesterone supplement to help seizures that happen around that time in some epilepsy patients. Now that's for progesterone. When it comes to estrogen, and to be more specific, estradiol, things are not as clear as for progesterone. The general rule or the general knowledge is that estradiol is pro-convulsant, meaning it facilitates seizure happening and lowering seizure threshold. And there are a number of proposed mechanisms for that effect at the cellular level, but I'm not going to get into much details about that today. Seizure exacerbation that happens in some women at menstrual correlate with the increase in estradiol just before ovulation, which is called estradiol surge. And in some women, when there is a cycle without ovulation, they might have seizure exacerbation the whole second half of the menstruation cycle. And this is due to an unopposed estradiol effect. So in general, estrogen or estradiol has pro-convulsant effect. However, there is also evidence in some models that estradiol can raise seizure threshold in the hippocampus, which is a part of the brain that's involved in epilepsy, and it making it less chance to have seizure. So this highlights like the complex role of estrogen in relation to seizure. But as a general rule, to make it simple, progesterone has anti-convulsant effect, estradiol has proconvulsant effect.
And you mentioned that in some women who that they can have seizure exacerbation for the whole a more extended period. Can you talk a little bit more about that? And then is there particular testing to see if you would fall under that category?
Right. Well, this is what we call catamenial epilepsy, which is a term used to refer to the cyclic exacerbation of seizures in relation to the menstrual cycle. And there are three commonly recognized patterns. One is the perimenstrual, which happens around menstruation. The other one is periovulatory, which happens around the ovulation, mid-cycle. And then the entire second half of the menstrual cycle, which is called the luteal phase in anovulatory cycles, meaning the cycle that does not have ovulation. Now, you asked me about some kind of testing we can do for this.
Right, particularly for that last one. Is that only a subset of people who experience?
Right. Well, there is no particular test for doing this. It all the diagnosis will depend on seizure calendar and correlating the information that we get from seizure calendar with the menstrual cycle and seeing when does the exacerbation happens.
Got it. Okay. All right. And can you talk specifically, so you mentioned catamenial epilepsy, which is correlated with the menstrual cycle. What changes do you often see in terms of seizure patterns or seizure types at both puberty and menopause?
Right. Well, with puberty, that's when the menstrual cycle happens, and in certain subset of women with epilepsy, they might experience exacerbation of their seizures during certain times of the month. For menopause, in general, the hormonal changes becomes less evident and not as periodic as when having menstrual cycle. So in general, we see decrease in seizure in this subset of patients who has catamenial epilepsy.
Okay. And several pediatric epilepsy syndromes begin around puberty. Is that thought to be related to reproductive hormones at all, or is it more likely related to changes in brain development?
That's more likely related to changes in brain development. The catamenial epilepsy has more to do with the exacerbation of seizures in someone who already have epilepsy around in certain periods of the month.
Okay. In your experience, how familiar are general practitioners and general neurologists with the connection between hormones and epilepsy?
Well, I think it varies depending on the interest of each individual physician and the patient population they see. General neurologists are usually familiar with the concept of catamenial epilepsy and the effects of hormones on epilepsy, but I have to emphasize that specialized epilepsy centers usually have more resources to help women with epilepsy, and the nursing staff as well as support staff in these centers have excellent experience with issues related to epilepsy.
Okay. So how common is catamenial epilepsy? I've heard everything from it being just a small subset of women to essentially all women with epilepsy who menstruate having some degree of catamenial epilepsy or at least some lowering of the seizure threshold as a result of the menstrual cycle and the hormones that you mentioned. In your experience, roughly what percentage would you say have at least some form of catamenial epilepsy?
Well, your observation is accurate. There are different numbers reported in literature, and this is due to the fact that different investigators use different definitions when studying catamenial epilepsy. So specifically, the investigators have differed in the definition of the phase of the cycle with seizure exacerbation under consideration, as well as the cutoff levels for seizure increase required to be designated as catamenial epilepsy. The most commonly used definition of catamenial epilepsy was described by an investigator called Herzog, Herzog, and is characterized by twofold increase in seizure frequency during one of the 3 times that are more vulnerable to have increase in seizure frequency that I mentioned earlier, compared with the seizure frequency during the rest of the month. And based on this definition, if we apply these strict criteria, catamenial epilepsy affects about 42% of women with epilepsy, which is still a large number.
Right. Okay, well that's very helpful to have an actual well-defined definition of what it includes. I think, and if you were to take a more broad definition, like any increase in seizure frequency or any exacerbation, then I imagine it would be a significantly higher percentage.
Exactly.
Right. Okay. Can you give an overview of the different specialized treatment strategies for catamenial epilepsy and then the relative effectiveness of each?
Sure. Well, catamenial epilepsy, to start with is an exacerbation of an already epilepsy syndrome that the patient has. So as with any other epilepsy syndrome, management should begin with the standard anti-seizure medications that are appropriate for the patient epilepsy type, and also consider epilepsy surgery for patients with intractable epilepsy. Now, when standard treatments have failed, several adjunctive treatments have been evaluated, and I have to emphasize the word adjunctive because they are not a replacement for the standard treatment. Rather, they are more as an add-on option. But the only problem is most studies evaluating these treatments have been small case series, so we don't have a lot of strong evidence. This has been studied like since the 1980s. One of the first drugs that has been evaluated for this is clobazam, or the brand name Onfi, and was evaluated in 1982 by using 20 to 30 milligram a day for 10 days per month, usually around menses, like 2 to 4 days before menses. And it did decrease like seizure in about 44% of patients, more than 50% decrease in seizure. So clobazam, number one. Number two, acetazolamide or Diamox, 4 milligram per kilogram per day, starting 5 days before menses for 5 to 7 days. The other medications are hormonal. So more than one drug have been tried. For example, gonadotropin releasing hormone analog, or GnRH. The brand name is triptorelin, 3.7 milligram muscular injection every 4 weeks. We can use medroxyprogesterone or Depo-Provera, either 120 to 150 milligram IM every 6 to 12 weeks. We can use also oral medroxyprogesterone, like 10 milligram orally 2 to 4 times a day for about 10 days. And finally, we can use progesterone lozenges, 200 milligram 3 times a day on days 14 to 25 of the menstrual cycle. So all these options have been studied. Some physicians also use the approach of increasing the standard seizure medication that the patient is already taking for about like 10 days a month or 15 days, depending on the period of time where we see seizure exacerbation. So, for example, if the patient is taking lamotrigine they can go up from 200 twice a day to 300 twice a day or so. So all these approaches have been tried and evaluated.
Okay, and are they relatively similar in terms of effectiveness, or is it kind of just on a case-by-case basis you try them until you find something that works appropriately and with limited side effects?
Right. It's mostly on case by case because most of these therapies are based on a small case series and clinical experience. Like for example, clobazam that I mentioned, the study that looked into it was 18 patients. Diamox or acetazolamide was 20 patients. So we don't have big number of patients in these studies. The strongest evidence we have is from randomized clinical trial that compared the efficacy and safety of cyclic natural progesterone therapy versus placebo in the treatment of intractable seizures. They looked at 294 subjects. 130 of them were with catamenial epilepsy. The study showed no difference in the primary outcome of more than 50% responder rates between progesterone versus placebo. But when they did further analysis, it showed that women with the pattern where seizure exacerbation happened around like menstruation time, about 20 to 57% of them had at least 50% or more reduction in their seizure. So progesterone may be appropriate for patients who predominantly have their seizure exacerbation around menstruation time. But the bottom line is more research. Bottom line, more research is needed to determine the best treatment for these cases. And until we have more evidence, it's going to be more based on experience and case by case.
Sure, which again emphasizes the need for an epilepsy specialist if you are experiencing those. Okay.
Exactly.
So can you talk about reproductive disorders for which women with epilepsy are at increased risk and why they're at increased risk and what, if anything, they can do to reduce that risk?
Sure. Well, reproductive dysfunction is unusually common among women and men who have epilepsy. In women, it generally manifests as menstrual disorder, excessive facial and body hair, and infertility, while in men it presents as loss of libido, impotence, and infertility as well. About 35% of menstrual cycles in women with epilepsy are anovulatory, meaning there is no egg production, as compared to 8 to 10% of controls, which is another cause of infertility in women with epilepsy. Polycystic ovary syndrome is the most common reproductive endocrine disorder in women with epilepsy as well as women in the general population, but it happens at a higher rate in women with epilepsy. In women with epilepsy, the rate is about 10 to 20%, while in the general population it's about 5 to 7%. This is regardless if the woman with epilepsy is taking anti-seizure medications or not. Now, to explain to our audience, polycystic ovary syndrome is a syndrome characterized by excessive body and facial hair, acne, irregular or no menstrual periods, pelvic pain, and difficulty becoming pregnant. Other issues that might happen, infertility is more common. So fertility rate in women with epilepsy is reduced to 70 to 85% of the expected number of offspring among married women. Premature menopause also is another reproductive endocrine disorder more common in women with epilepsy. The average age of natural menopause in the U.S. women is 50.5 years, but in premature ovarian failure or premature menopause is defined as natural menopause that occurs before age 40 to 45 years, and it affects 1 to 2% of women by age 40 years in the general population. But in women with epilepsy, the number is higher. In one study, it was found to affect about 14% of women with epilepsy. Now, why does it happen? As we know, epilepsy is a disease of the brain, and it can affect a part of the brain that has a critical role in regulating reproductive function as well as sexual behavior. This part is called the hypothalamus. The hypothalamus produces a hormone called gonadotropin releasing hormone, GnRH, which regulates the pituitary gland secretion of two hormones, FSH and LH. These two hormones regulate the ovaries' function of producing estrogen and progesterone, and they also regulate the ovulation. Now, there are regions of the hypothalamus that are involved in the regulation, production, and secretion of GnRH. These regions receive extensive connections from the cerebral hemisphere, especially part of the brain called the temporal lobe and the limbic structure, which are commonly involved in epilepsy. And there seems to be some sort of disruption of the normal function. Now, in addition to epilepsy itself, anti-seizure medications may also change endocrine function, producing some reproductive disorders. For example, phenytoin and carbamazepine lead over time to diminished activity of estradiol, which may lead to some menstruation disorders. Valproic acid also appear to be associated with frequent occurrence of reproductive endocrine disorders like polycystic changes in the ovaries, excessive testosterone, and menstruation disorders.
Okay. And then is there anything in particular that can be done to either prevent or address the increased risk for these conditions?
Well, to reduce the risk or impact of these disorders, I do have a few recommendations. One, reproductive function should be screened regularly for menstrual disorders, infertility, obesity or weight gain, excessive body and facial hair. And if we find some reproductive dysfunction, then further assessment with endocrine testing, pelvic ultrasound, pituitary imaging may be necessary. The diagnosis of reproductive endocrine disorder should be also considered in terms of etiology and potential contributing factors, including like epilepsy and seizure medications, especially valproic acid. And then we should evaluate the possible benefit of changing anti-seizure drug we should balance that against efficacy in terms of seizure control and the side effects of alternative agents. Now, having said that, I have to point out that it's inherently difficult for a physician to actively inquire about a medical condition that's far outside their comfort zone. So, for example, a neurologist inquiring about these endocrine disorders, and for most neurologists, it would be most appropriate to refer such patients to a gynecologist for further evaluation and treatment.
Okay, and is there, let's say, a woman is experiencing some symptoms that may be consistent with one of these disorders, should she advocate for her epileptologist to work with an endocrinologist or a gynecologist, or how do you coordinate care between the different providers?
Well, the neurologist job or the epileptologist job will be to inquire or try to screen for these disorders. Okay. And yes, he should coordinate care with an gynecologist or an endocrinologist that has experience with working with women with epilepsy.
Okay. You mentioned that epilepsy can affect the function of the hypothalamus, which in turn can affect sexual behavior. Can you talk a bit more about this impact and also discuss how anti-seizure medications and then also anxiety related to epilepsy can both affect sexual function and behavior?
Yeah, let me start by saying that most women with epilepsy maintain normal reproductive cycle and sexual life, but significant minority, about 20 to 30%, have some degree of sexual dysfunction, including problems with seizure exacerbation, libido, arousal, and orgasm. The most commonly reported problems, about 30% or a little over 30%, are reduced sexual desire, orgasm problems, and vaginal dryness. Some studies suggest that psychosocial factors such as depression, feeling stigmatized from epilepsy, and being anxious about having seizure during sex may contribute to the higher rate of sexual dysfunction in this patient population. Anti-seizure drugs may also affect sexual function in women by alteration of some neurotransmission or a substance in the brain called the serotonin, which might lead to some sexual dysfunction as well. And enzyme-inducing anti-epileptic drugs like phenytoin, carbamazepine, phenobarbital may also adversely affect sexual functioning by decreasing some hormonal levels. So all these factors might play a role in causing some kind of sexual dysfunction, and again, referral to an obstetric or an gynecologist is important in these cases for managing and trying to fix the problem.
Okay, and then again, depending on the severity of the problem, the epileptologist may also be able to adjust the anti-seizure medications if those are found to be the primary cause or the suspected primary cause of these symptoms.
Right, exactly, and coordination between the epileptologist and the OB/GYN specialist is very important in these cases.
Okay, great. So how do anti-seizure medications affect birth control pills? What extra precautions may be necessary?
Quite a few anti-seizure medications do affect hormonal contraception, especially oral, like birth control pills, as well as some other forms like transdermal patch or vaginal ring. These meds are usually inducers of an enzyme in the liver called the P450 system, and this induces the metabolism of both estradiol and progesterone. This medication list includes carbamazepine or Tegretol, the brand name, oxcarbazepine, eslicarbazepine, clobazam, phenobarbital, phenytoin, primidone, and rofinamide. Topiramate also decreases estradiol levels, and both perampanel or Fycomba and lamotrigine decrease progestin levels. Now, the good news is that there are quite a few medications that have no effects on hormonal contraception, like ethosuximide, izogabin, gabapentin, lacosamide, levetiracetam, pregabalin, vigabatrin, zonisamide, and valproate. Both the CDC and World Health Organization advise against combining enzyme-inducing anti-seizure medication with combined oral contraceptive pills, the vaginal ring or the transdermal patch. Some authors have previously recommended using combined oral contraceptive pills with a higher dose of ethinyl estradiol, but there is no evidence that exists to support this approach. In fact, there are some reports of contraceptive failure in women taking higher doses pills of oral contraception in addition to enzyme-inducing anti-seizure medication. Now, both CDC and World Health Organization say that depot medroxyprogesterone acetate The brand name is Depo-Provera, which is an injection typically given every 12 weeks at a dose of 150 milligram. Can be used safely in patients taking enzyme-inducing anti-seizure medication, and no adjustment of the dose is recommended. Now, the method of choice for most women with epilepsy for contraception is Intrauterine Device Iud. There are 3 types of IUDs available in the United States. One is copper IUD, and 2 that are hormonal. One is 52 milligram and the other is 13.5 milligram. The copper IUD is approved for 10 years of use. The hormonal ones, one is approved for 5 years of use and the other one for 3 years. And both the copper and the hormone-releasing IUDs are relatively free from clinically significant drug-to-drug interaction and can be used safely, and they are effective. A study that looked at the efficacy of the 52 milligram hormone-releasing IUD found a failure rate of about 1.1% per year. And although this is slightly higher than the failure rate of 0.2% seen in larger general population studies, it's still much lower than that of other contraceptive options. So if a woman wants to choose a method for contraception, a woman with epilepsy who is on anti-seizure drugs, probably IUD would be the best choice for her.
Yeah, and presumably if you wanted additional protection or reduction in the risk of pregnancy, you could also use condoms or some other additional device.
Right, definitely. Using the barrier methods like condoms.
Yeah.
Now, also we have something called emergency contraception. Like in the United States, this is called the morning after pill, which is available in the form of 2 0.75 milligram levonorgestrel pills taken 12 hours apart. We don't know the effect of enzyme-inducing anti-seizure medication on this morning after pill, but it can be used also. We can use also copper IUD that is inserted within 5 or more days of intercourse. Can also provide highly effective emergency contraception as well.
Okay. How do anti-seizure medications affect bone health? And again, what extra precautions may be necessary in women who are taking the anti-seizure medications that are most likely to affect bone health?
The use of anti-seizure medication is an independent predictor of increased risk of osteoporosis, which is a disease where there is decreased bone mass and bone strength, and increased risk of fractures in the future. And this is due to the effect of mainly enzyme-inducing anti-seizure medications on vitamin D. The current evidence suggests that young adults may be at particularly increased risk of bone loss. Low calcium intake and vitamin D deficiency may aggravate these bone effects and are potentially treatable factors. Inactivity is another important factor associated with bone loss and needs to be considered in management of bone disease associated with anti-seizure medication. Now, the problem is that despite the evidence suggesting adverse effects of anti-seizure medications on bone, there appears to be a general lack of awareness among physicians about these effects. And more attention needs to be given, and guidelines for screening and treatment need to be established. Discussion of the risks associated with anti-seizure medications and good bone health practices should be part of the evaluation of a seizure patient. Now, I recommend for every patient who has epilepsy and taking anti-seizure medication to start doing good bone health practices like regular weight-bearing exercise, adequate sunlight exposure, adequate intake of calcium, and avoidance of risk factors of osteoporosis like smoking and drinking alcohol. Also, vitamin D and calcium supplements should be considered for patients taking long-term enzyme-inducing anti-seizure medications, as well as monitoring vitamin D level and doing bone density scan periodically to monitor for bone health.
Okay, great. Can you talk about some of the key issues women with epilepsy should consider when contemplating or preparing for pregnancy? It's a lot to consider, so you can talk about some of those different considerations.
Right. This is a very important topic and a big topic. Let's start by talking about the malformation risk in pregnancies exposed to anti-seizure medications. We know that pregnancies exposed to anti-seizure medication the first trimester have an increased risk for what we call major congenital malformations. Those are defined as an abnormality that interferes with function or requires surgery or both. I'm talking about abnormality in the baby. Now, it's important to point out that major congenital malformation can occur in healthy women at a rate of 1 to 3%, depending on the population that was studied. So any woman who gets pregnant who doesn't have epilepsy, who's not taking seizure medication, have 1 to 3% risk. For women with epilepsy, the risk is about 4 to 6%. This is based on studies as well as pooled analysis of many studies. And all of our information about this are from pregnancy registries like the North American Anti-Seizure Medication Pregnancy Registry, Australian Pregnancy Registry, International Registry for AED, etc. To talk about individual drugs, if we look at all registries, it was found across all of them that valproic acid or Depakote is associated with the highest rates for major congenital malformation. The studies report anywhere between 4.7 to 13.8% of malformation. Now, in contrast, we have studies that have shown relatively low malformation rates with lamotrigine and carbamazepine exposure, so they are a little safer to use in pregnancy. Levetiracetam, or brand name Keppra, looks promising also, although more studies are needed to confirm this early trend. Phenytoin, phenobarbital, and topiramate likely has an intermediate risk of congenital malformation, whereas data on most other anti-seizure drugs are too limited to stratify. I should mention that for the majority of these structural abnormalities, the risk is highest in the first 8 to 10 weeks of pregnancy, when the woman is not even still aware of that she is already pregnant. So this highlights the importance of early preconception planning. Now, having said that, I want to stress out the importance of remaining on anti-seizure medication during pregnancy, because we know that there are risks associated with having seizures during pregnancy, like exposing the fetus to anoxia or lack of oxygen, increasing the risk of the mom injury, uterine contractions, fetal heart rate changes. There is also an increased risk for preterm labor and small for gestational age infants if the pregnant woman is having seizures. So while risks related to anti-seizure use in pregnancy exist, they can be minimized by early counseling. And this counseling should start no later than prescription of the first anti-seizure medication to a woman of childbearing age, which is often well before the patient expresses an interest in becoming pregnant. I'm sorry, what was the rest of the question?
No, that's a major part of it. So, does seizure during pregnancy also expose the fetus to the risk of trauma? I mean, actual physical trauma from falls, or
Right.
are they relatively protected from that, or?
Well, relatively yes, but if a woman has like a generalized seizure or partial seizure and she falls down and hits her abdomen, yes, the infant is exposed to trauma as well.
Right. Okay.
Now, a question I get a lot is, what happens to seizures during pregnancy? Do women experience more seizures or less seizures during pregnancy? And
Right.
What we know is that most women with epilepsy will not experience a change in the frequency of seizures during pregnancy. In about 1/3 of the patients, or fewer than 1/3, they experience increase in seizure frequency. And in a minority of patients, about 10 to 20%, there is a decrease actually in seizure frequency. Now, what predicts if the seizure gonna get worse or during pregnancy is the level of seizure control before getting pregnant. And it was found that women who are seizure-free in the 9 months before getting pregnant, they have about 84 to 92% chance of remaining seizure-free during pregnancy on their current regimen. And now this brings me to another topic, which is the need for adjusting the dose of seizure medication during pregnancy.
Right.
We know that for certain anti-seizure medication, their metabolism changes during pregnancy. This is especially true for lamotrigine, where its clearance increases by over 200% over the course of pregnancy. And lamotrigine dose need to be increased substantially over the course of pregnancy to maintain the pre-pregnancy levels. And doses of over 600 milligram a day are not uncommon by the end of pregnancy. Oxcarbazepine, or the brand name Trileptal, clearance is also increased while during pregnancy, while this doesn't happen much for carbamazepine. So adjusting the dosage for anti-seizure medication during pregnancy is an important part of caring for a woman with epilepsy, and should be directed by checking the level whenever possible. So ideally, the level should be checked and established before getting pregnant, and then during pregnancy it should be checked monthly for most drugs, especially for women on lamotrigine or oxcarbazepine.
And then presumably after pregnancy as well, I assume you can see dramatic changes then.
Right. Now, in the case of especially lamotrigine, the pre-pregnancy clearance rate is reached within 2 to 3 weeks after delivery, and to avoid toxicity, the patient should be given a plan before delivery to reduce the seizure medication dosage after delivery. So monitoring, establishing level before getting pregnant, monitoring the level during pregnancy every month or every 6 weeks, and then adjusting the dose again after delivery.
Right.
Now,
what about concerns about breastfeeding? What have the studies shown in terms of passing anti-seizure medications on through breast milk?
We know that the benefit of breastfeeding have been well established. I mean, this includes decreased risk of many diseases in the infant, like infections, decrease of breast and ovarian cancer in the mom. Also, breastfeeding promotes mother and infant bonding. For most of seizure medication, there is this theoretical concern of prolonged infant exposure to seizure meds, but it was found that it does not outweigh the known benefits of breastfeeding. In fact, in one study, children exposed to carbamazepine, lamotrigine, phenytoin, or valproate in breast milk as infants had higher IQs and language scores at 6 years of age when they were compared with children whose mom chose to not breastfeed them because they were taking anti-seizure medication. So it's safe to breastfeed the child. In fact, it has a lot of benefits that outweigh any presumed risk.
Okay, great. And if someone is considering pregnancy, another concern, particularly if their seizures aren't fully controlled before pregnancy, is the impact of epilepsy on parenting and being able to care for your baby and your child. How do you counsel patients regarding those concerns?
It's important to discuss seizure safety with the patient and her family. So we encourage breastfeeding, but the sleep deprivation that's associated with trying to feed the baby every 2 to 4 hours may lead to lowering the seizure threshold in many women with epilepsy. So family members should be asked to help with night feedings with either expressed breast milk or formula, so the patient can get a stretch of uninterrupted sleep, typically 6 to 8 hours. Now, other safety recommendations, I recommend giving the child bath only in the presence of another adult, just in case the patient has a seizure. When changing diapers, prefer to do it on a pad on the floor instead of a changing table. Avoiding stairs when possible, especially when you are holding the baby. And using a stroller instead of an infant carrier strapped to the mother. So all these things, if you do, try to reduce the risk of having a seizure, the risk associated with having a seizure on the baby. So all these things should be discussed with the patient, like during pregnancy or before pregnancy, as well as after delivery.
Okay. What are some key tips to help women coordinate care between the OBGYN and the neurologist when becoming pregnant? And is epilepsy considered, or pregnancy in a woman with epilepsy, is that still considered a high-risk pregnancy?
Yeah. Well, I can't emphasize enough that planning is the key here. Planned pregnancies are usually best for women with epilepsy because it gives the patient time to work with her neurology or epilepsy specialist or epilepsy team and the obstetric team as well ahead of time. Unfortunately, about half of the pregnancies in the U.S. are unplanned. So I recommend for every woman who has epilepsy and who is childbearing age to talk to the healthcare team about pregnancy early on, even if she is not planning to have a child at the moment. And try to get a health team willing to work together with the patient before, during, and after the pregnancy. And ideally see a neurologist who is specialized in epilepsy and an obstetrician who is comfortable with epilepsy. And most importantly, you want both doctors to work well together and with the patient. The patient also can add a nurse or a social worker or other mental health counselor to her team because she will likely have many practical questions about pregnancy, safety, and parenting issues to address. And it can be an emotional time too, so having support is crucial. Try to review the seizure medications and seizure control with the epilepsy team before becoming pregnant. And if you are planning to get pregnant, you have to plan for frequent visits to the neurology team during pregnancy and also pay a lot of attention to healthy living and seizure triggers. And finally, don't forget that this is a family affair, so the spouse, partner, and key family and friend support should get involved as early as possible.
Right. And you mentioned mental health. It just made me think of postpartum depression, because people with epilepsy are at increased risk for depression when compared to the general population. Is it also true that women are at increased risk for postpartum depression?
Right, yes, that's true. Women with epilepsy are at an increased risk for postpartum depression, and this is another issue that needs to be discussed with the healthcare provider before and after delivery, and the patient and family should be aware of this early on as well.
Great. So if a patient is on Depakote or valproate, and this so far has been the most effective treatment for her seizures, how would you counsel her if she was considering pregnancy? So basically, does the risk of congenital disabilities from staying on Depakote outweigh the risk of breakthrough seizures from switching medications?
It's a tough question. I mean, we know that valproic acid has the highest risk of both congenital malformation and cognitive abnormalities in a developing child. So in general, it should be avoided in women of childbearing age. Valproate also was found to be associated with decrease in mean IQ by 10 points in kids for women with epilepsy who use Depakote during pregnancy. There is also increased risk of autism and autism spectrum disorders in exposed children. And the higher the dose, the higher the risk. But there is no known safe zone for valproic acid during pregnancy.
Right.
Now, if the patient seizure is only controlled with valproic acid, I usually explain to the patient the risks associated with valproic acid in the case that she got pregnant, and then we'll leave the decision about trying to get pregnant or not to her. Now, to reduce the risk of malformation, the only thing we know can help is taking folic acid or folate. It's a vitamin. It should be taken daily prior to becoming pregnant, and since most women do not know that they are pregnant until after the time that the neural tube close in the developing fetus, which is like 28 to 28 days after conception, I recommend that any woman of childbearing age who has epilepsy and taking anti-seizure medication should take folic acid every day, regardless if she's planning to get pregnant or not. And the recommended dose is 0.4 to 4 milligram. I usually go with 2 milligram. Some women use prenatal multivitamin that usually has about 0.4 milligrams, so it's not enough. I recommend adding 2 milligram of folic acid on top of that to be taken every day, again, regardless if planning to get pregnant or. So yeah, taking folic acid is the only thing we know that can help with this.
Right. And I know you're not a pediatric epileptologist, but at what age typically do you think the conversation should begin between the neurologist and a teen with epilepsy regarding switching off Depakote if they're on it?
Well, it should be started as early as possible, or we can say as soon as the patient start having menstruation and there is a chance of becoming pregnant.
Right.
Then we should start talking about this. Try to switch as early as possible.
Sure. So before we open it up for questions, do you have any closing thoughts on this topic, or anything that we didn't touch on that you feel is important to discuss?
Well, I want to say that women who have epilepsy, they have the right to live a normal and healthy life and have children like anyone else. And there are certain risks involved due to epilepsy and its medications, but with careful planning and counseling, the risk is reduced and it's doable. Women with epilepsy should be counseled early and regularly about reproductive health as it relates to epilepsy. And the selection of anti-seizure medication for women of childbearing age should take future pregnancies and contraceptive needs into consideration, and try to avoid valproic acid if we can. And if it's prescribed, it should be kept to the lowest dose needed, and using folic acid all the time, regardless of planning to get pregnant or not. And if we need to do any changes in anti-seizure medications, it should ideally be initiated at least 1 year before getting pregnant.
Great. All right, well, I think we will go ahead and open it up to questions, and I'm just going to switch the mode here just a second.
Sure.
And I do encourage people, again, if you're not asking a question, please to mute your line by dialing *6 or by using the mute feature on your phone. And if you do have a question, you can unmute your phone or dial *6 to unmute as well. So, okay, just a second here. Okay, does anyone have a question they'd like to ask? No one has a question? Okay, is anyone with us still? Okay, Faith. Go ahead.
Yeah, I have a question just out of curiosity. Would there have been any birth defects if I were on Dilantin, a possibility of that?
If I understand the question correctly, you asked what's the risk of birth defects if you are on Dilantin, correct?
Correct.
Yeah, there is a risk, and Dilantin has like intermediate risk, so it's more than when you are on lamotrigine or levetiracetam, but it's less than when you are on Depakote. So I would go with about 4 to 6% risk of birth defects.
Okay.
Now you can look at this in two different ways. You can say this is double the risk for the general population, or you can look at it 94% chance at least of having a normal baby with no birth defect.
Okay, thank you.
Sure.
Okay, other questions?
Yes, I would like to know. Okay, I noticed that a lot of doctors don't really talk about Dilantin as far for the seizure medication. I do take Dilantin. I've been taking Dilantin probably for about maybe about over 10 years, 15. I'm just saying, do you is there a time when you change? Because I know I'm gonna have to be on some kind of seizure medicine for the rest of my life. Is there a suggestion that a different medication, or how do you go about really trying to base for medication? When it comes down to the seizure medication.
Well, in general, it has been my practice that I don't prefer to use Dilantin in young patients, because we know Dilantin in particular, not only in women, in men and women, has long-term side effects. So I usually try to avoid starting it, and if a young patient comes to me and he is already on Dilantin, many times I try to switch to a different medication Now, keeping in mind that every time you lower the medication or you try to switch, there is a risk of seizure involved. But what I usually do is start a newer medication and make it overlap with Dilantin, and then after I reach a good dose on the second medication, I try to taper down Dilantin. So did I answer the question?
Yes, I think. Because so it's Dilantin. That's the oldest seizure medicine that they started. When they started issuing seizure medication, Dilantin was the one, and then they progressively got medication when it came to the seizure medication.
Right. I think phenobarbital is the oldest, and then Dilantin is the second oldest. Yeah.
Oh, okay then.
Yeah, phenobarbital, Dilantin.
I'm sorry.
Can you talk a little bit?
Yeah, sure.
Can you talk a little bit more about the specific long-term effects of Dilantin that are concerning?
Right. Well, we know that Dilantin has probably a little higher risk of affecting bone health, and it affects the way the patient looks, cause changes in the gum, gingivitis or inflammation of the gums, and teeth issues. And it also interacts with a lot of medications that the patient has to be on later in their life. So all these issues can happen with Dilantin.
Yeah, it surprised me when you had said with the gums or whatever, because I just recently, had went to the, to the dentist, and I had they were doing a deep cleaner as far as my gums. But
yeah.
I'm a person that really does, do brushes very well. But I'm just, just hearing you say that, I was just I'm surprised now.
Right. I mean, Dilantin does that, and if I have a patient on Dilantin, I always recommend seeing a dentist at least 2 times a year, maybe more sometimes.
Yes, I do follow through with that, but I was just I see now, because I just was wondering, because they were saying that my gums bleeding, they say it's not coming from they say from what they seen that I do brush well or whatever, but they noticed that I have some bleeding.
Some bleeding, yeah, that happens.
Right.
Yep.
Other questions?
Hi, I have a question. I am taking clobazam and trileptal, and I was just wondering if you have any information on those medications, kind of whether there's big increases in birth defects or just in general.
So the question is, what's the risk for birth defects or for trileptal and Onfi or clobazam?
Yes.
Correct. Yeah, I mean, both medications, we don't have enough information on the risk, how much the risk is with them. But I mean, I would go with general risk for anti-seizure medication, which is about 4 to 6%.
Okay, thank you.
Yeah, sure.
Okay, and I'm still hearing some background noise. The mute feature is *6 if you have background noise. Yep.
Yes, this is Faith again.
Yeah.
Yes, I asked the first question about Dilantin and birth defects. I've been on Dilantin for decades, and you had mentioned something about calcium and folic acid and vitamin D. Are those 3 I should be taking, correct, every day?
That's correct. Calcium supplement and vitamin D supplement and folic acid. The folic acid is about 2 to 4 milligram every day. Vitamin D, I would recommend anywhere between 1,000 to 2,000 units every day.
And the folic acid is only really for children or for women of childbearing age, correct?
Correct. That's correct.
Okay. Okay. Other questions?
Yes. This is Tanya. Okay, you saying folic acid is only because I take folic acid. They recommend because I'm on Dilantin, so I had to take the folic acid with my with the Dilantin.
Right. Folic acid is only if there is a chance you might get pregnant.
Oh, I see what you're saying. Okay.
Or if you are in childbearing age, it's to protect the baby more than anything else.
And then also, you also was recommending the vitamin D 1,000 milligrams. That's for women of childbearing age. Is that what you were suggesting?
No, for vitamin D, it's for everyone. For everyone who is on anti-seizure medication for a long time, I recommend vitamin D 1,000 to 2,000 units a day.
Okay, so you will. Oh, okay. So that's preferred. That would be vitamin D by itself, not with some kind of multivitamin. But the vitamin D by it. Okay.
Yeah, multivitamins usually the amount of vitamin D in it is about 400 units, which is not enough.
Okay.
So you have to add to that vitamin D supplement.
Oh, now how would you go really suggesting as far for? I know I just heard you saying 1,000 to 2,000. Well, it just depends or whatever. But how would you suggest how you recommend as far for if I was going to the vitamin D, me choosing like 1,000 milligrams compared to a 2,000.
Right. Well, ideally we need to check the vitamin D level, and then if there is deficiency, we can replace that. There are different ways to do this. Some physicians choose to use 50,000 units a week for 12 weeks and then put the patient on maintenance dose. But if that's not available or it's not done, 1,000 to 2,000 is a reasonable dose. And taking extra, when you take some extra, your body is going to get rid of it, and you will not experience toxicity unless you are taking 10,000 or more than 10,000 units a day for a long time.
Oh, okay then. Well,
and just to clarify, this is units, not milligrams, right?
Exactly, those are units.
Yeah.
Okay, units. Oh, so it's different. So if you now, is this prescription per se, or is it over the counter? So I make sure that I'm understanding.
We can give a prescription, but it's also available over the counter. You can find it in any drugstore, in Costco, Sam's Club, and anywhere they are available.
Okay, so I'd be looking for 1,000 or 2,000. What you say? Not milligrams.
Units, or international units. I think it's.
Oh, international units.
Exactly, international units. And
okay, so I know what how I go about picking it up. Thank you.
Right. Sure.
Okay. Other questions? Okay. Does anyone have any comments that they'd like to share? Anyone who's maybe had experience with pregnancy or had experience with catamenial epilepsy, who has who'd like to share their challenges or maybe share some successes? Or go ahead.
I did have another question.
Yeah, go ahead.
I was muting the line when I got the answer for the folic acid and calcium, but how many units to that?
For folic acid?
Yes.
It's 2 to 4 milligram a day.
2 to 4 milligrams per day. Okay.
Right. And again, this is
the calcium?
only for childbearing age.
Okay, so I don't really need that to help me with my bones then, or?
No, the folic acid doesn't have anything to do with bones.
Oh.
You know, it's
Okay,
only
I thought it did.
for women who are who might get pregnant
Okay.
or in childbearing age.
And the
Yeah,
calcium?
the folic acid is to prevent neural tube defects specifically.
Okay.
So, yep.
And how much
And
calcium per day?
The calcium is usually it's available over the counter. There are different combinations. I'm not sure about the number, but I think it's anywhere between 200 to 500 milligram.
Okay.
As a supplement.
Oh. All right. Thank you very much.
Sure.
Okay. Any other questions? Or again, we'd love to hear any experiences from anyone who has dealt with hormone-related seizures or catamenial epilepsy, or has gone through pregnancy with epilepsy. If anyone would be willing to share their experiences, that would be great.
Well, I don't know if this related, but I came across really with my seizure. And like I said, I've had it. I see it was 20, but it was over 30. Over 30 years ago, I was pregnant. You know, at the time. You know. And,
when you developed epilepsy.
Yes, that's right. That's when I developed it. You know, when I was pregnant, and it was just shocking because then it really had it related to my brain tumor. You know.
Oh. Okay.
So yeah, so we talking about from more times I haven't had. Thank God I haven't had a seizure as of the last seizure I had was in 2004. That was when. Could you explain the difference? Could you tell me what's a grand mal seizure?
It was a grand mal seizure, you said, or you want me to explain what is a grand mal seizure?
Yes, could you please?
Well, grand mal seizure is the term used to talk about what we call generalized tonic-clonic seizure, where the patient typically loses consciousness and becomes stiff all over his body or her body, and then starts shaking all over. This might or might not be associated with loss of bowel control or bladder control or biting tongue. Some people also experience foaming from the mouth, and their eyes might roll up or to the side. This is what we call grand mal seizure.
And does that mean that it just come on you all at one time and you're not aware? It just because basically, like when I have my seizures, I'm waking up in a hospital. I can talk to you right now, and I have a seizure, and then I don't know anything about it, and then I'm in the hospital.
Right. Some patients they are not aware of it, and there are a group of patients who feel something unusual just before they experience the seizure. This unusual feeling is called aura. So some patients do have something they feel, but for some patients it just happens suddenly and they don't have any feeling. And a lot of patients they have no idea what just happened, like your case.
Right.
I think it's important to emphasize too that a generalized tonic-clonic seizure of a typical duration, or that lasts for 5 minutes or less, is not typically a medical emergency. So if you're ending up in a hospital every time you have a tonic-clonic seizure, that's not necessary. So really the guideline for when to call 911 is if the seizure lasts for more than 5 minutes, or if the seizure stops and then is followed immediately by another seizure without you fully regaining consciousness. those are what we're concerned about, which is called status epilepticus, where it's prolonged seizure activity or one seizure after another. But a typical single generalized tonic-clonic seizure is usually not considered a medical emergency. So you may want to talk with those around you to make sure that they're not unnecessarily calling 911.
Right.
Okay, let me go a little bit further into it. What happened was that, like I said, I probably have a total of how many. The times that I'm discussing as far for when I, had a seizure, I had a tumor on top of it. Which I had brain, I had brain tumor. Mm-hmm. So, each time that's how they found out, it was something, because they literally been in my head 4 times. And each time something significant always was taken. Last time was with my sight. First time was the smell. So it seemed like every time I did have those seizures, something else happened. Besides that seizure.
Okay.
So, I don't know. That's why why the doctor was. I was just curious. But whenever, I was just, last time, thank God it wasn't. But I know each time it was identified with a tumor.
Okay. Any other questions or comments?
No. I really enjoyed it.
I have a question that related to the fact that psychogenic non-epileptic seizures are more likely to be experienced in women. Have you found, Dr. Assaad, that there is maybe a tendency among general neurologists or among those less experienced with psychogenic non-epileptic seizures to jump to the conclusion that if it's a woman who's having seizures and they have a normal MRI and a normal EEG and maybe the seizure doesn't look like a typical seizure, is there maybe a bias in some providers in terms of jumping to the conclusion that seizures are psychogenic non-epileptic seizures just because it's a woman and they're more likely to occur in women?
Well, I have seen both. Have seen some get labeled as psychogenic non-epileptic while they are actually having real epilepsy syndrome.
Yeah.
And I have seen also some patients who are on seizure meds for many years and they end up being found to have only non-epileptic psychogenic seizures or episodes, I should call it.
Mm-hmm.
So yeah, I have seen both. And you are right. Psychogenic non-epileptic episodes are more common in young women and older men for some reason also.
Okay.
So there might be some tendency to label a young woman who has atypical features on her seizure and has normal workup or initial workup to be labeled as non-epileptic psychogenic episodes. Which highlights the importance of following up with an epilepsy center and getting admitted to epilepsy monitoring unit for further evaluation when there is something atypical.
Right. Okay. All right. Well, last chance for any other questions or comments. Anyone? Okay. Well, I think we will go ahead and wrap it up then. So thank you so much, Dr. Assaad, for a very thorough and enlightening discussion. And I'm going to have to go back and listen to it again a few times as we covered so much information. So luckily, this has been recorded, so it will be on our website. So if anyone does want to go back and listen to any particular part, you can do so. So thanks again, Dr. Assaad, and thank you everyone else for participating.
Sure, it was my pleasure.